Good evening. Welcome to the Ask Me Anything. Got some questions about some of the topics that I usually hit upon that help you reduce your risk of heart attack and strokes. Didn't see any biohacking questions this week, I don't think, but that's okay. Been doing a couple biohacks this week, playing around with the old Apollo Neuro. Had it for quite a while. Vibrates at different frequencies, helps with kind of stress responses, may help with relaxation, but I was playing around with it because there's an integration with it that works with the Oura Ring. I did not personally find it to be that useful for me, so I'm not going to continue with that regimen. But there is an integration where if you wear this while sleeping, and the Oura Ring gives data that it looks like you're starting to wake up from your deeper levels of sleep, this thing will start vibrating at different frequencies and try to drive your sleep back down. I did not notice any improvement in my sleep scores for the couple nights I was using it, so I'm not going to continue to use it because I'm personally not a huge fan of having devices that are on Bluetooth always mode pinging in the middle of the night, because I usually keep the Oura Ring on airplane mode when I'm utilizing it at nighttime. So if you have the Apollo Neuro, let me know if it works for you. But I did not see any improvement when I was doing it for the sleep optimization. And then still playing around with the Actia band, and now they've been rebranded as Hilo. I don't know yet when this is going to be released in the United States. I have a message out to the company to see when they might have some estimated shippings into the U.S. Interesting device, but until they have it available here, not worth the hassle of trying to get it from overseas, because you'll have a very difficult time getting the software to work without some IT skills to be able to get it from a foreign app server. So those are the kind of the gadgets I've been playing around mostly this week. In a couple weeks, I'm going to be going down to Houston to hang out with my friend Dr. Lyon. We're going to record another podcast. We're going to be talking about the endothelioglycocalyx. We're going to be talking about the keto CTA trial. We'll be talking about some of these home devices you can utilize to test your arterial health. So be on the lookout for that podcast in the next couple of weeks. And then also got some more details about the Canyon Ranch retreat that I plan for later this year. Up for debate, but it'll be late October, early November. Probably be like a 2-3 day type of event. Pretty informal. There's not going to be scheduled hours where you got to be somewhere, or scheduled lectures you got. Most of the time, it's going to be you're doing the type of activities that you want to do. I'm up very early, obviously, see every sunrise. So if you want to see some sunrises with me potentially, or go to breakfast, happy to have you along with that. And then I usually go on different hikes early in the morning, and then potentially some classes, and then kind of the relaxation stuff in the afternoon. So if you're interested, a couple people direct message me. Some patients from Apollo are starting to message me with that. I have some details. It'll be a deluxe room. There'll be an 800 reservation number. Once I kind of lock in the dates, you'll call the 800 number directly yourself. You arrange payment directly to the Canyon Ranch. I don't accept any payment. There's not a fee from my standpoint to do this. I'm not charging a fee above whatever your room and board would be. But if you're interested in that, be on the lookout for my newsletter. That'll be out in hopefully the next week or so. And then I'll keep giving updates on my social media handles. So with that admin out of the way, I'll jump into the questions that were submitted today. So first question up today: would I please comment on red light therapy eye protection? Yay or nay? I would estimate that you're talking about, when you say red light therapy, you're talking about photobiomodulation. There are certain protocols that the light therapy can be directly into the eyes, but you have to have the exact wavelength that they use in the trials, ideally, and the right irradiance or power density. And in that case, no, you do not use eye protection. Most other consumer devices, for the most part, unless you're shining it directly in your eyes, you do not need to be protecting your eyes. It'd be the same as, do you always protect your eyes when you go outside? No, generally you don't. If you're going to be directly looking at something, then potentially you would protect your eyes. Then this is a favorite question of mine. Can plaque build up in the arteries be reversed? The short answer is yes. I see it all the time with my patients at Apollo Cardiology, and I've definitely seen it in my own case a couple times. Carotid and coronary plaques improved. Never really had carotid plaque, but it was more carotid thickening, so the intimal thickness was improved. But typically, you got to get to the root cause of things. You have to figure out what's impacting the endothelioglycocalyx and potentially lowering nitric oxide pathways. You have to make sure you keep oxidative stress and inflammation low. And then often you got to consider using some type of nutraceutical or pharmaceutical intervention to work on lipoproteins if they're not controlled with lifestyle interventions. So definitely possible, but it's a test, don't guess philosophy. Just looking at blood work won't be enough. You have to actually look for the plaque and see the plaque, do whatever intervention you're going to do. And then generally, it depends on the test, but usually somewhere, the 12-month window, you'd repeat some type of imaging to look to see if you made an improvement. And this kind of follow-up question that just tags along with it. I believe you're trying to mention that there's arterial, which says, does arterial, which I would suspect is arterial, which is an endothelial glycocalyx promoter supplement. Does it really remove plaque? And can you take it with statin and an aspirin? So not medical advice. I can't tell people what they're allergic to or if there's any drug or nutrient interactions, but typically I do have some patients that take all three of those combinations. But definitely there is data, more in the carotids than coronary so far, that product can get soft lipid-rich plaques and carotids to shrink up to 40% in less than 4 months. The coronaries, they don't necessarily have as much research on that. My own N of 1 experiment is that I was taking arterisol for a while, and I had a coronary plaque improve by 6% in less than 2 years. And while that may not sound like a lot, statins really only lower plaque by 1 to 2%. All right. Question about the CMT. How much value is the CMT in tracking plus labs for cardiovascular disease risk if resources are limited? Okay. So if it was a financial decision, the CMT is probably a better test than doing blood work. The blood work is not predicting risk. You want to look at plaque because plaque begets plaque. So if you have intimal thickening in plaque, you want to do something, lifestyle, supplement, or medication to treat the plaque. The blood work just points you in the right direction. And it depends on where you get the test done, but most CMTs are generally around $200. Somebody says that they have microvascular disease and they have angina. They also think it may be in their brain area. What test is required? Again, I can't provide direct one-on-one medical advice in this case, but if you have endothelial dysfunction in your coronary arteries, it's very likely to have endothelial dysfunction in cerebral arteries. So testing that looks at nitric oxide includes pulse wave velocity testing. The product we use is called the Max Pulse. The Endopat, which looks at reactive hyperemia, tells you how much nitric oxide the arteries can release when blood flows through them. Blood tests including uric acid, homocysteine, asymmetric dimethylarginine, symmetric dimethylarginine, homocysteine. Those are things that if they're abnormal, they may be affecting your nitric oxide pathways. There's test strips that can look at oral salivary nitrite. And then if it's brain, you need potentially some type of imaging of the brain. So either an MRI or a CT angiogram of the brain, potentially. But you got to talk to your doctors who have been treating you for that to get that ordered. And a question, are there any types of exercise that can damage the heart and arteries? The short answer is yes. Think of exercise as a drug. No drug, no benefit. Very large window of benefit, but at some point, the volume of exercise will outstrip your body's ability to recover from that volume of exercise. So exercise is going to contribute to oxidative stress and inflammation. If you have enough time off, you sleep well, you recover from that stress, and you can do it again. So there's definitely data that people who are endurance athletes tend to have elevated CT coronary calcium scores, probably because it's an inflammatory cascade. The good news is they tend not to have stenotic lesions, so they're not symptomatic, but plaque is something that builds up even in very well-conditioned athletes. So just because you look healthy on the outside doesn't mean the cardiovascular system on the inside is healthy. So that's why you do imaging to look. All right. So that was the pre-submitted questions. So saw a couple comments popping up. Happy to answer those. Is there a recommended light protocol for Parkinson's? There very likely is, but this is outside my area of expertise. I would look at the information on the V-Light, V-I-E-L-I-G-T-H, V-Light, L-I-G-H-T. Their website has some brain photobiomodulation devices, and they do have consultations with people to discuss, if their devices would be beneficial for the issue that the person's interested in, and they might be able to talk about protocols. Thor laser also tends to have some protocols, but you have to work with somebody who has those type of devices. All right. How far out are the new medications for LPLA? I've heard later this year and 2026 early is probably the release dates, one of the two agents. Would it be recommended for anyone with abnormal LPA? The short answer is no, because the studies that the FDA is requiring of the companies are only looking at patients as secondary prevention, meaning the patients have already had heart attacks, strokes, stents, bypass, and they have to show that the medications lowering LPA is not only safe, but it actually reduces cardiac events. If it just lowers LPA and the people continue to have heart attacks, they're not going to release these drugs to the population. If somebody just has high LPA and never had an event, they will be able to be prescribed the medication. Any doctor who's able to prescribe anything that's on the market, even if it's quote off label. But if you're looking for insurance coverage for the drug, they're not likely to be covering this for primary prevention to begin with. I have no inside knowledge on this, but if it follows with what happened when the PCSK9 inhibitors hit the market over a decade ago, those drugs were only released for secondary prevention. And at the time of release, they were well over $15,000 a year without insurance coverage. Suspect LPA drugs will probably be in that kind of ballpark range as well. So in the interim, lower the LPA things that you can, including LP-2 activity, oxidized phospholipid ApoB, interleukin-6. Those are the three big labs on the Boston Heart Lab panel. I can tell you, is LPA a problem for your arteries? And then lower the ApoB particles that are on the LDLs. All right. So Instagram makes it hard to read numbers sometimes. So somebody says it looks like they have very high total cholesterol, LDL, and normal range HDL. So ApoB is 125. That's going to be well above the 80th percentile. Calcium score 0, so no hard calcified plaque, no high blood pressure. So do you need meds to lower cholesterol, to lower heart disease risk? Again, can't answer that, as one-to-one. That is something you got to discuss with your doctor. This is what I do with my patients at Apollo Cardiology, is we risk stratify them and talk about, the options that people could consider. The Boston Heart Lab panel, you can look at the cholesterol balance test on that to see, are you a hyperproducer of sterols or you're a hyperabsorber of sterols? If you're a hyperproducer of sterols, statins or Nexletol tend to work better. If you're a hyperabsorber of sterols, ezetimibe tends to work better. If you're taking oral medications and not getting to the goals that you and your doctor want, then that's where the PCSK9 inhibitors can be beneficial. Really, the only downside is that they're, right now, subcutaneous injections that you give yourself twice a month. There are oral versions that are in works but not ready for prime time yet. So lipids may need to be managed. It's a good starting point to have a calcium score of 0, but calcium scores are not perfect test. 8% of people who have a calcium score of 0 still have significant plaque in their arteries and should be treated if needed. So this is why we do comprehensive testing at Apollo Cardiology. We look at carotid disease. We look for coronary disease. We look for abdominal aortic disease. We look for peripheral arterial disease. And if there's still concern, then send for a CT angiogram to look for the soft plaque in the coronary arteries. But lipids are important, but you have to also have optimal nitric oxide pathways, a healthy glycocalyx, and low oxidative stress and inflammation. All right. So I think I got the questions answered tonight that you needed. I'm going to be back next week. I'll hopefully have a little more details about the Canyon Ranch, kind of pseudo retreat, meaning that I'll know the dates and how you're potentially able to schedule yourself if you'd like. I'll drop a link in my story after this, which just has a generic website link so that you can learn more about the Canyon Ranch in Tucson. Amazing facility, one of my favorite places in the world to go to. Excellent place to kind of get re-equilibrated with light water magnetism if you're more of the quantum, or if you're just more interested in learning better nutrition strategies, exercise strategies, stress management technologies. That place has it. So looking forward to that event. It'll be late October, early November. If you're interested, stay on the lookout for this. So but there's one last question, and I'll answer that, and then I'll pop off here. So somebody says that they have a 24-year-old employee with a recent diagnosis of myopathy. Would depend if it's a cardiomyopathy or if it's a muscle, like skeletal muscle issue. If it's cardiomyopathy, younger people tend not to have ischemic, so it means probably not a blood flow issue to the heart. More commonly, it's a infectious cardiomyopathy. Could be long-standing hypertension cardiomyopathy. Could be a autoimmune mediated issue. So if the heart isn't working well, you got to do a workup to figure out why the mitochondria aren't working well. So echocardiograms, cardiac MRIs are the starting point for that to figure it out. So hope you guys have a great week. I'll see you guys next time.